Very good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for AOFOG, who has already invited me to give a talk in AOFOG Campus 4 with the topics about adenomyosis. So at this point, I will discuss about adenomyosis related infertility. What are the treatment options? If it looks that adenomyosis, maybe also has been explained by the previous speaker, is intramyometrial presence of endometrial mucosa, including both of glands and stroma, surrounded by reactive hypertrophic myometrium. This adenomyosis characterized by the presence of ectopic endometrial glands and stroma in the myometrium. Based on histological diagnosis, and adenomyosis was made, the diagnosis was made histologically when endometrial glands and stroma were found at least one low power field beneath the endometrial junctions more than 4 millimeters. So we can see the adenomyosis if endometrial glands and stroma were found at least be more than 4 millimeters at endomyometrial junctions. The island of adenomyosis may be scattered throughout the uterine musculature. Adenomyosis can be diffuse form, or localized, the focal form recognized as well as adenomyoma. This is a example of diffuse adenomyosis, and this is example of the focal adenomyosis. How was the histogenesis of adenomyosis? At least there are three theories very important regarding the histogenesis of adenomyosis. Number one is the invagination of basal endometrium that would proceed along intramyometrial lymphatic systems. The second thing is about the adenomyosis originated from deep part basal of the endometrial mucosa, or the last adenomyosis may be originated through metaplasia from the novel ectopic intramyometrial endometrial tissue. When it happens, adenomyosis occurs when the normal boundary between endometrial basal layer and myometrium was disrupted. So that's why this is risk factors associated with adenomyosis, which is consistent. For example, number of births, spontaneous abortions, and then a history of dilatation and curettage, menorrhagia, and also endometrial hyperplasia. And other risk factors were inconsistent. What is the junctional zone? The junctional zones mean the inner myometrium represent a highly specialized hormone-dependent structure. Yeah, the junctional zone change with age and also disrupted in several reproductive disorders, including endometriosis and also adenomyosis. We can classify adenomyosis based on adenomyotic involvement of the inner third to third or entire myometrium. So we can calculate penetration ratio. This is the depth of penetration over myometrial thickness. And the second, the number of endometrial island observed at histological examinations. What is the adenomyosis prevalence? If you look these tables, adenomyosis prevalence was ranging from 14% until the highest is 57% across many studies. So it becomes a good question whether adenomyosis is a variant. Is it not a disease? This, I think, the evidence from hysterectomized menopausal women in the study of women's health across the nations. Adenomyosis is equally common, found in women with have fibroid, endometriosis, pelvic pain, or abnormal uterine bleeding, and also women who do not. If we calculate, adenomyosis was found in 40% of among 137 patients. Can see here no difference, adenomyosis and no adenomyosis uterus in case of prolapse, vaginal bleedings, fibroids, pelvic pain, suspicious mass, or patient with stress urinary incontinence. This is very important, the pathophysiology of an estrogen-dependent disease. Instead of aromatase activities, also sulfatase activity is very important, converting, activating estron sulfate into estron, and then estron can be converted into estradiol by 17-HD hydroxysteroid dehydrogenase type 1. So the local estrogen production may increase the estrogen concentrations, which together circulating estrogen that is stimulate the growth of tissue mediated by estrogen receptor. How was correlation between adenomyosis with hyperplasia, endometrial hyperplasia, and with endometrial cancer? Study done by Kitawaki looks that 35% adenomatous hyperplasia coexists with adenomyosis. So please be very careful. If we have adenomyosis patient, we should be very careful about the presence of hyperplasia. And also endometrial cancer. In endometrial cancer, at least 33 to 38% adenomyosis was present. And 60% of adenomyosis present endometrial cancer. In endometrial cancer versus 39% in normal patients. So in endometrial cancer, 60% of adenomyosis was present. So please be very careful. If you found adenomyosis patients, please be careful about the possibility of adenomatous hyperplasia and also endometrial cancer. If we want to diagnose adenomyosis, sometimes no symptoms are pathognomonic. Yeah. Clinical presentation sometimes is very few asymptomatics, uterine bleeding, dysmenorrhea, present symptoms in the big adenomyosis, and also infertility. So the diagnosis of adenomyosis has been presented by the first speaker and the second speaker. It's very important to know pathognomonic of clinical symptoms, and you can use TPS on the MRI, and it's a golden standard of histopathology. This is, for example, diagnosis of adenomyosis. If you look transvaginal ultrasound, the sensitivity about 81% and specificity about 71%. MRI increasing the sensitivity and specificity up to 86% to 100%. So that's why MRI is very important to make a diagnosis of adenomyosis. The probability of adenomyosis with an abnormal transvaginal ultrasound was around 66.2%. And the probability of adenomyosis with normal transvaginal ultrasound only 9.6%. So that's why transvaginal ultrasound also really important in making diagnosis of adenomyosis. We look this figure, junctional zone more than 12 millimeter is highly predictive of presence of adenomyosis, while junctional zone below than 8 millimeter is unlikely to have adenomyosis. MRI is an accurate, non-invasive technique for diagnosis of adenomyosis with high sensitivity up to 88% and high specificity up to 93%. So that's why nowadays people believe in MRI instead of transvaginal ultrasound. The practice point transvaginal ultrasound is useful as screening tool in most patients. TVS also limited value in patients with coexisting fibroid. MRI has a higher diagnostic capability, especially in the presence of fibroid. The parameters should be indicated to describe adenomyosis. Number one is the present. It should be more than 2.5 millimeter from endomyometrial junction. Depth of penetration can be mild if the penetration up to 1/3, moderate between 1/3 to 2/3, and then more than 2/3 the penetration we recognize as severe disease. The degree of the spread of the condition in terms of number of the islets. Yeah, grade 1 disease is 3 islets. Between 4 to 10 is grade 2 disease, and more than 10 islet maybe adenomyosis was classified grade 3 disease. Also very important configuration of lesion, whether diffuse or nodule or focal. How is the correlation between adenomyosis and infertility? We know that adenomyosis patient will suffering from dysmenorrhea, dyspareunia, and abnormal bleeding, and how big the risk of to become infertile. If you look these tables, this is a long study done by Breton 2004, Fisher, and Costello. This is case control study. Adenomyosis strongly associated with long primary infertility in baboon. Yeah, it's not in human, even in the absence of co-16 endometriosis. And then Fisher, this is cross-sectional studies, hoxaten gene expression is decreased in patient with adenomyosis. Of course, this is the cause of infertility. And the last, the presence of TVS diagnosed adenomyosis did not adversely affect outcome in women undergoing IVF or ICSI. So if you look this figure, sorry. Yeah, the next about the diagnosis adenomyosis and infertility, the invasion of basal endometrial gland and stroma, and sometimes can disrupt the normal architecture of underlying dysfunctional of myometrial peristalsis, increase intrauterine pressure. So that's why that's why in adenomyosis patients, some patients also suffering from infertility. This because of impairment sperm transport, dysfunctional myometrial hyperperistalsis, increased uterine pressure, and also dislocation endometrial cells in peritoneal cavity. This is the management strategies, medical. I will not talk about this. And then JUS, danazolute, iodine, GnRH, aromatase inhibitor, or continuous OCP. And then the surgicals can be done by radical hysterectomy, uterine artery embolization, or conservative surgery. I think this is very important. The pain reduce up to 90%, considered because increasing age, quality, and psychosocial. If you look the impact of adenomyosis on women's fertility, if you look this one, the study of GnRH in women with adenomyosis, I think this was the treatment period with adrenaline agonist. 5 months, 3 months, 6 months, 6 months over the 3-year period. This is pregnancy outcome and duration and fertility in interval between spontaneous pregnancy and completed treatment. Yeah, sometimes it's 1 month, 5 months, 4 to 6 months, or even 12 months, and between 5 to 18 months. Yeah, there's some good criteria. And then if you look again, the conservative surgery. How was the conservative surgery? This pregnancy outcome is clinical pregnancy. This one we can see duration of fertility. This 4 years, secondary infertility, 3 years to 6 years, 6 years. The interval between spontaneous pregnancy and completed treatment. Yeah. The interval between spontaneous pregnancy and completed treatment up to 30 months. Yeah, you can see 30 months is almost below almost 3 years. And sometimes 20 to 50 months is almost 4 years more. Yeah, it's very interesting. And then the impact of adenomyosis is combined therapy, generalized agonist with surgery. I think also with some with one with danazol. I think this one interval between spontaneous pregnancy and completed also quite vary. 12 months, 4 months, 12 months, 36 months, 3 months. Yeah. There is a place to do surgery, and also there is a place to give medicamentos or medicine to patient with adenomyosis with infertility problem. And if you look the combination, the outcome, how was the outcome after surgical with medical or surgical alone? If you look this one, the symptoms, reproductive outcome also no significantly difference. Term pregnancy, preterm pregnancy, abortion, successful pregnancy, and clinical pregnancy. This is one of example conservative surgical management for diffuse uterine adenomyosis. So the procedure should be considered as therapeutic option in women with symptoms of diffuse uterine adenomyosis who wish to avoid hysterectomy. Yeah, we can do the conservative surgical treatment. The second surgical treatment is laparoscopic excision of uterine adenomyoma done in 6 conservative women with adenomyosis and then was successfully managed, appears to be safe and feasible with good follow-up result and limited recurrence rate. The last is conservative surgery introduced by Professor Osada in Japan. I also study with him to do Osada surgery. This is a very good surgery techniques in order to avoid high recurrence and spontaneous rupture after adenomyosis surgery. By radical, this is the radical section of adenomyomatous tissue, and then also do the triple flap method for reconstructing uterine. This is the technique, Foley catheter function as tourniquet to prevent bleeding. After 3 flap, the tourniquet can be removed because the flap then prevent further bleeding. Yeah, I think this is, for example, incise mediana, then penetrate from U3 to the as a biomarker. We can put our finger into uterine cavity and then we do the stitching, suturing after we excise the adenomyosis. How's the outcome? This is Professor Osada study in 10-year study in Nihon University Hospital and St. Luke Hospital. You can see patient who decide to conceive is 25%, and then patient become pregnant in desired pregnancy is about 66.5%. Almost all the patient underwent elective cesarean section. Two suffering from abortion. This is the pregnancy coming from IVF and then spontaneously only very few. So then the patient's success rate to get pregnant after OSADA procedure is 61.5%. This is a little bit of our experience in the first year doing OSADA procedure in RSM. You can see there are 18 patients for 3 months. I think up to now we have done maybe more than 200 cases. Yeah, you can see here the patient's age, then first cohort, pre and post-op is really different. Yeah, this is the pre-op and post-op. Adenomyosis 70 millimeter diameter. Then also operation and the blood. If you look this one, this is the surgery what I did in Osada's procedure in very huge adenomyosis. I think almost 9 centimeters. The patient suffering from 11 years fertility. You can see here. Yes, this is what I did the adenomyosis resection, and then by scalpel. And after we identified very well which part is uterine cavity, because later when we do the stitching, our finger was also entered the uterine cavity as the guidance. This is the second flap. Before is first flap, this is second flap. Then yeah, the last is triple flap. So that's why yeah, this one after triple flap. Osada mentioned the risk of uterine rupture is very few after they did the Osada's procedure in every adenomyosis patient. Okay, and then yeah, fortunately after 9 months after surgery, patient got pregnant from IVF. You can see here 8 weeks. However, unfortunately, 11 weeks the baby was dying. I don't know what's happened. This is, for example, one of patient with adenomyosis patients in the left side after Osada procedures. the reconstruction. Then she got pregnancy, natural conceive, and then this after delivery. You see, no different. Yeah, there is no adhesion, no risk for having rupture because we do the triple. The other data also, this is the outcome of conservative surgical treatment of adenomyosis in our study. I think adenomyosis, the resection is most likely, yeah, conventional resection is almost the same. I think, yeah, most likely conventional compared to OSADA. Betul. And if you look the variables of symptoms, no difference. This was the nature of the pregnancy. The pregnancy is natural pregnancy, OSADA, only one, conventional with 7. Pregnancy with IVF, OSADA 2, then conventional, no. I think the OSADA procedure also a little bit promising if you look the number of pregnancy, natural and both of natural and IVF after we did removal of adenomyosis itself. Yeah. The last as a take home message is we know that adenomyosis is an estrogen dependent disease which has correlation with endometrial hyperplasia, endometrial cancer. TVS and MRI could be used in diagnosis of adenomyosis. Conservative surgery is an option for patients with infertility or other psychosocial reasons. And the last OSADA's procedure appears to be effective in reducing patient symptoms and give patient chance to become pregnant. I think this is my presentation. Thank you so much. Good afternoon, everyone.